Şimdi değerli konuklar, NHS Danışmanı Profesör Doktor Mahmood Adil'i davet ediyorum. Sağlık Bilişiminin az maliyetli kaliteyi artırmadaki rolü konusunda bizlerle çok değerli bilgilerini paylaşacaklar.
Very good afternoon. I think this is the last session, and you must be very tired. And I will do my best to finish it in 25 minutes. First of all, thank you for inviting me. And it is always very nice to be in Turkey and see all the developments Turkey has done in informatics. But I will spend next 25 minutes to talk about, in particular, about how the data could help to improve quality and decrease cost. This is the outline of my presentation. First of all, it talks about how the modern and effective health information system look like. Secondly, I like to show some examples. One example from England and example from Turkey, which shows that you can improve quality and decrease cost by using the data very effectively. And then thirdly, I would like to make some suggestions which could help to enhance the health informatics systems in Turkey. I think even 10-15 years ago, people talk about information, and this information was only accessible to very few people. But now we live in information age, and information is open to everyone. So it has been exploited and exploded. So you can see that now with your iPhones, and you can get even the hopefully ICD-11 on your iPhones. So you could see that how the information is going to be accessible not only to professionals but to everyone. Modern health informatics. I just say there are three things every modern health informatics system need to think. These are three steps. The first one is the data. You need to collect the data. Second one, change into knowledge. And third, use the knowledge to do some actions which could improve quality for your patients, and it can decrease cost. Let me start with data. These are the few steps every healthcare system need to have in place, that you collect data. First you need to have a very clear purpose why you are collecting data. Before you start any information system, you need to be very clear the purpose of collecting data. Then you need to have a good information management and computers and the way you collect data. Then you need to analyze data. Then you change into some system which can people use to make decisions, decision support system, and change into knowledge, and the people should use that knowledge to make difference in patients' lives. When we talk about knowledge, there are two questions I would always ask about knowledge. First one, how the knowledge is presented. If you go 10-15 years back, people were collecting data and presenting it in spreadsheets. Spreadsheets are not easy to understand, and doctors, nurses, they have got more important things to do rather just to read the spreadsheets. So we need to be thinking that how best we can present the data which can look like a knowledge, either as a report, and more important nowadays, that you can put them as dashboards, which can one page, which can just tell you that what this knowledge is all about. The second question I asked, actually, who you are targeting this knowledge to. If you are not clear from the outset that why you're collecting this data and who you are presenting this knowledge to, then it would be very difficult that you can change into actions. The usual targets are, first of all, the patients. You can present the information to the patients and to the public in such a way so that can help them to improve their health, to professionals, to Ministry of Health, and of course, you talk about international agencies, because WHO, World Bank, they are always keen to access good quality data from every country. So these should be the target of any modern health informatics system. And then third step, I said, in any modern health informatics system should be the actions. So you have collected the data, you have changed into knowledge. Now you need to use the knowledge in order to take some actions which can improve patients' lives. And in terms of actions, you need to be clear about two things. One, the focus. The focus of your actions are first the quality, because the key purpose of every healthcare system in the world is to add life to years and years to life. It means improving mortality and morbidity. And if you're not able to do that, then even with the best health informatics system, you are actually wasting the resources. So the focus is on quality. But now we are facing big financial challenges all across the globe. No country, even America, which spend about 17% of their GDP on health, they are not able to cope with the burden of disease. So the cost is becoming paramount. So if we have to improve quality, then we need to think about at what cost. And then the next question you need to ask when thinking about actions, that at what level you have to take actions. If you are a health manager, you need to be thinking that I should take actions with my data at the local level, with public or private hospitals. Then you go to the national level, and then you go to the international levels. So when you think about actions, first thing you need to think about the purpose of actions. Is it cost or quality? And the second, at what level you would like to take actions, whatever data you have. Now I would like to show you an example from England, that where we have got a pretty good system. It's not perfect. We are still trying to improve it, but we are using our system in such a way so that we can improve quality and decrease cost. You can see that these are the three pictures I took from the newspapers and from economists. First thing definitely show that our habits as a human beings are changing. It means that we are getting very unhealthy. So our diet, our exercise, smoking, all those factors are making us more prone to chronic diseases. Second, this is our Minister of Finance, who is announcing that the economy, the UK economy, will still be facing challenges in another 4 or 5 years. Our budget is £105 billion. So every year we are spending £105 billion in the NHS in England. But our needs are £125 billion. So we have got £20 billion gap. To fill that gap, we need to think how best we can use the data which can give us the evidence, we can improve quality and decrease cost. And the third thing, which I showed from the newspaper Daily Mail, it shows that diabetes is becoming paramount, maybe all over West. 10% of our budget in the NHS is just spent on diabetes. We have 2.4 million people, our population is 60 million, and 2.4 million people are with diabetes, and we will have 4 million if we keep on doing like this in another 10 years. So the biggest budget spent as per disease is the diabetes. So we call it value-based healthcare. So if you want to deal with this challenge where you have got chronic diseases, patients are getting older, elderly population, then you need to be having a value-based healthcare. It means you need to look at your outcomes and those outcomes, at what cost you have achieved those outcomes. So cost, outcomes divided by cost. And when I talk about outcomes or quality, we defined quality and outcomes very clearly in the National Health Service. There are three things we always ask in the NHS. Our doctors and nurses, they work very hard to achieve those. First one is safety. So we don't expect that when the patients goes to our hospitals, they get infection, the hospital-acquired infection. We don't expect they should be falling in our hospitals, having fractures, and any other harm. We call it safety. That's the first thing we expect. Second thing is the clinical effectiveness. So we should be using evidence-based to make the best available treatment to our patients. And the third thing is patient satisfaction. If those three things are not being done, then we don't say that it is a high quality care we are providing, whether it is for knee replacement, for diabetes, or for asthma, for any condition we deal with, we look at those three things. And then we have got a national information center which coordinate all the data collection activities for the health and social care in England. And they collect the data, they clean the data, and they present it back to the NHS. That's what they do. So they don't decide things. They collect the data, they analyze it, and they present it back to the NHS. So they take the data from primary care, secondary care, and tertiary care. They put it in this hint, which is their computers, and then we look at where the gaps in services, we look at how the medicine is being used, we looked at where the high-risk population live, and we look at a number of other things. So this is the way the Health Information Center collect the data from primary, secondary, tertiary care, but they collect the data based on the purpose, and these are some of the purposes why we collect the data. And then not only that, we also make this data available on the internet. These are the few of the websites. Even if you want to go now, you will find this data available to everyone. So you can make a comparison between, if you live in Manchester and someone live in London, you can go on this NHS comparator and you can compare that what are the outcomes of the patients with diabetes in Manchester as compared to the patient living in London. So this is not only for health professionals, anyone can access this data. So we have done two things. One, we have centralized the data. It means data is coming at one source and then we are giving to everyone. And then second, we are trying to make it available as much as possible to public, patients and professionals. The other thing, this is about outcome data. This is now about cost data. We have got 250 trusts, we call them our hospitals. There might be about 400 hospitals. And we ask them to implement PLEX, that is patient level information and costing system. And this system does three things. It looks at the activity, expenditure, and cost. I can show you that in every hospital, even in Turkey, there are three systems. There are clinical systems like all the labs. Then there is a electronic patient record. And the third thing is the financial system. So we try to bring all those three things together to change into knowledge. So this knowledge could be used to improve quality and decrease cost. So this is patient level costing. We get the activity data, we get overhead and staff cost, we get expenditure, and this is the outcome. Then now, all those hospitals who have got PLEX, they can tell you that how much it costs to treat a knee replacement for every patient. And you can also see if there are 3 doctors who are operating on they operate on 3 different patients for knee replacement, it can tell you how much each patient costed. And if you can look at the outcomes are same and the cost is different, then of course you ask the question from the doctors that how come one doctor cost is more than the other. And this is one of the results that you can see that this shows the number of doctors and their costs. So we can see that how different doctors are treating different patients and how much those patients are costing us. The other thing we did, because we wanted to improve quality and decrease cost, and you can't deal with all the things at the same time, so we decided that we need to look at our high volume care. So where our most of the procedure which are being used for most of the patients. So these are the 8 procedures which are being used most commonly in England. So now we know with help of our data that these are the 8 procedures and one of them is knee replacement. And then we asked all the hospitals that which hospital is providing high quality, low cost care, and we came to know that the best hospital is having averages 6.5 days. So some hospitals patients stay more than 6.5 days. So we try to reduce the number of days, and by doing that we can improve quality and decrease cost. So by using data we were able to show that where the high volume is, how that high volume is linked with cost, and how the best hospital is dealing with those high volume care. And we asked the average and poor hospital that they should try to match their quality, with the best hospital. So by doing that, we are able to improve quality and decrease cost in the NHS. This is another way of putting the dashboard. I mentioned that you need to present the knowledge to the doctors in such a way that they can understand it and then they can use it to take some actions. So this is another dashboard which shows then when patient fall in hospital, how much that patient costs you. So when they see this dashboard every day, then they know they're losing money. This is another example about diabetes in England. So these are the first map is the diabetes now, and the last is in 10 years time. The darker the color, higher the diabetes, and you can see the diabetes is increasing. And this is because we were able to use the public health and epidemiology data from the whole England to be able to project these numbers. Then what we did, we start looking at the complication of diabetes. So amputation is one of the complications of diabetes. So these are the different provinces or different parts of England, and we look at how much those patients, which part of England having more amputation. It means their diabetes was not well controlled. So this is called NHS Atlas of Variation, and if you Google it, you will find that we have got this Atlas of Variation for all the conditions. So by looking at it, you can understand that we are able to look at the outcome. And then we ask the doctors that they should control the diabetes better in those cities. And you can see the results. The diabetes care is 6 times cheaper in England as compared to America, and our outcomes are better than America. This is because we were able to use the data very effectively, and we were able to target our efforts to improve the outcomes of diabetes only in those parts of the country where we feel that diabetes care is not provided to high standard. So by doing that, we were able to show that by spending even 1/6 of the amount as they spend in America, we are able to achieve the same outcomes. Now, example from Turkey. A Turkish clinical quality program which was started almost 14 months ago, and the previous Minister of Health and now the current Minister of Health is very keen that how best we can improve the clinical quality in Turkey. And I'm going to show you that what data we are collecting to reflect the clinical quality in Turkey. And the aim is that we need to make the clinical quality from good to great in Turkey. And that is their logo, which is, hopefully you will start seeing them everywhere, in every hospital soon. So the Turkish clinical quality assessment system is being established to answer 3 questions. The first question is, what is the level of clinical quality in Turkey? How much it is being assessed, and how it should be assessed in future. So these are the 3 questions you can only answer with help of a good data. So we identified some pilot provinces. So these are the names I'm sure you all are familiar with. So these are the pilot provinces where we picked primary care centers, public hospitals, private hospitals, and university hospitals. And these are those provinces where we are doing those pilot, but inshallah it will be spread all over the country soon. And these are the 6 conditions we started with. So these are the 6 conditions. There is a comprehensive data is being collected. We call them quality indicator data on those 6 conditions: diabetes, knee replacement, maternity, stroke, hip replacement, and coronary heart disease. So once we are able to collect this data, what we did, that we defined the data, what data need to be collected, then identify the quality indicators, and then use the Turkish current health informatics system, that's SalıkNet 2, to collect the data. We are analyzing the data, and it will be presented back to all the hospitals that how good their quality is on all those 6 conditions. And this is the screenshot of a computer from of a doctor in hospital. That's the way they are putting the data about diabetic patients. So when a patient goes to primary care or to secondary care in Turkey, the doctors see this screen, and he or she has to fill those quality indicator data, and data is getting collected through SalıkNet 2 in this way. So primary care, secondary care coming to SalıkNet, and then data is collected, it go to data warehouse, and then clinical quality reports are going to be produced. So this is the picture of the clinical quality in Turkey. It will look like in 6 months' time, when we will be in a position to say that data has been collected, analyzed, cleaned, and the quality reports are being produced. That is what we are doing for the pilots. And now, last 2 or 3 slides. This is all about that quality is a journey, and it is not a destination. You need to keep working to improve quality. And then the idea to suggestions for improving the health informatics system is that if you don't have a good health informatics system, it would be very hard to understand the baseline for your quality, understand how much it is costing you, and understand how to put your efforts on the focused area to improve quality. So the first idea is that I told you about 3 steps: collecting data, changing into knowledge, and knowledge into action. So you need to do it. Sooner you move from one step to another, the better it is, because the bigger the gap from collecting the data to change into knowledge, many things get missed out. The bigger the gap from knowledge to action, then many things again missed out. So the first thing is decrease the time between the 3 steps. Even if you're working in hospital, Ministry of Health, or internationally, that's the first thing you should be thinking. Second, information overload. As I've seen few presentations before, nowadays we live in information age. It means we get bombarded with information through iPhones, through computers. but if it is not focused information, then the doctors and nurses and managers, they lose their interest very quickly. So the challenge is that whatever you present, it should be relevant knowledge, not everything. So second thing is information overload. And third thing is integration. We talk about primary, secondary, tertiary care, but if you have got public health data, all things should become together. I hope the SalıkNet 2 in Turkey is able to do that, but I think this is the future. This is what we have done back home in England, that we are trying to integrate the data. So it is no more primary care, secondary care, tertiary care data. We call it health data. And this is one data set, and everyone can take out what they like. Fourth point is, I've seen all those companies over there and here. These are, and I have been to the exhibition, these are very innovative companies. And I think you need to find the ways to encourage the information management and technology companies to come up with the solution you're looking for. So you need to give them the problem which you have got in your hospital, in your primary care setting, rather than they go and start building a lot of solutions. You need to give them the target. So that is the way you can encourage the innovation. And in England, we have got innovation hubs. So we call them academic health and science networks. So that is where the industry, academia, the universities and hospitals work together, and they try to find the solution, and most of them are IMNT companies. And last but not least, it is very important that, as Professor Bahadin said this morning, that you need to have leaders in health informatics. So you need to build this thing in your undergraduate and postgraduate courses so that you can develop the leaders who can lead with health informatics. So it is a big discipline. You can't learn this overnight. It needs to be having a systematic approach, both in the medical schools and the management schools, that they need to teach about health informatics in a more systematic manner. And now, the benefits. I'm advising the Ministry of Health, and I always see that Turkey has got a huge potential. Its healthcare system in last 10 years has really become an example of best practice all over the world, saying in 10 years how much progress has been made. But I think the time has come that you need to start thinking about taking health informatics more seriously. Why? The first thing is, it will help you assess the standard of care in Turkey. It is very hard for you to say that where the standard of care is better, in Izmir, in Istanbul, or in Konya, if you don't have a good data. So that is the first benefit you will get, that if you have got a good health informatics system. Second is, it will give you the evidence for excellence, which private and public hospital have got excellent care. And then third thing is about achieving medical tourism, because I always think that if you have got high quality, low cost care, then Turkey will become very attractive to many mainland Europe, to Middle East and to North Africa, because high quality, low cost care will bring benefit to many international patients. And I know the ministry has given this target, that they are thinking that by 2015 they should have 500,000 people who should have been treated, international patients should be treated in Turkey with 7 billion revenue. It is quite a target, and I feel that this target can only be achieved if you are able to show the world that the Turkish healthcare system is high quality, low cost system, and the only way you can show it you need to collect evidence, and you can only collect evidence by collecting data, analyzing it, changing into knowledge, and knowledge into action. So this is the summary, that from data to knowledge to action. If you don't do that, the chances are, in spite of your dedicated effort, you won't have a system which is a universal, high quality, low cost system. So take the data, change into knowledge, focus the knowledge, change to actions, and these should be your actions. Thank you.